In this module, we will review the risks of surgery. This discussion is important for two reasons. First, understanding the risks of surgery allows you to make an informed decision about whether you want to live with your pain and limitations or whether you want to take on the risks of surgery to try to make them better. Second, many times this discussion helps patients to understand why it is important to prepare for surgery thoroughly, as well as follow various instructions before, during, and after surgery. In other words, if you understand the problems we are trying to prevent, you are more likely to follow the instructions that will help you get a good result. This discussion is not a legal disclaimer like the piece of paper next to a bottle of medication. It doesn't list every single thing that has ever gone wrong with these surgeries. Rather, we've chosen 3 of the serious risks and 9 of the more common risks. The goal of this discussion isn't to scare you or make you anxious. Instead, we are hoping that it empowers you to help yourself get the best result possible. There are many rare but serious problems that have been reported after hip and knee surgery. 3 examples of these are dying, losing your leg, or serious artery or nerve injury. By choosing Geisinger and choosing a high-volume surgeon, you've done what you can do to reduce the chance of these serious risks, because they have all been shown to correlate with the volume of surgery being done by the hospital and the volume of surgery being done by the surgeon. Furthermore, Geisinger Health System has been recognized nationally for its excellence in hip and knee replacement surgery. We are one of 13 hospital systems across the entire United States that was chosen by Walmart, Lowe's, and 4 other major companies to be a center of excellence for hip and knee replacement surgery. So patients come from all over the country to have their surgery performed at Geisinger. We will now review 9 of the more common risks. These include infection, fracture, dislocation, limb length discrepancy, loss of motion, instability, persistent pain, loosening of the parts, and blood clots. We will address these risks one at a time.
No surgical procedure is without risks. Unfortunately, a small percentage of patients undergoing hip or knee replacement, roughly about 1 in 100, may develop an infection after the operation. Infections in joint replacements may occur higher up in the skin or deeper around the artificial implants. An infection may develop during your hospital stay or after you go home. Joint replacement infections can even occur months or years after your surgery. Any infection in your body can potentially spread to your joint replacement. Infections are most often caused by bacteria. Because joint replacements are made of metal and plastic and do not have their own blood supply, it is difficult for your immune system to attack any bacteria that make it to the implants. If bacteria gain access to the implants, they will multiply and cause an infection. Some people are at a higher risk for developing infections after a joint replacement procedure. Factors that can increase the risk for infection include medical problems such as diabetes, vascular disease, obesity, and any disease or medication that weakens your immune system. Diagnosing an infection requires a variety of tests that will be ordered by your surgeon. These tests include X-rays and other types of radiology scans. Special orthopedic blood work will be ordered. Fluid will also be removed from your joint replacement by your surgeon or another doctor so it can be analyzed for evidence of infection. Despite antibiotics and preventative treatments, patients with infected joint replacements often require surgery to cure the infection. There are a variety of surgeries that are used to treat infection. Some surgeries are focused on the skin and soft tissues. Other surgeries involve the deeper implants. The most common surgical treatment of infection is a 2-step process. The first step involves removal of the infected joint replacement and insertion of a temporary antibiotic joint replacement. Infectious disease specialists will then treat your infection with several weeks of intravenous and oral antibiotics. After antibiotic treatment, a second surgery is required to remove the temporary antibiotic implant and insert a new permanent joint replacement. Additional antibiotics are often prescribed following this second surgery, and lifelong antibiotics are sometimes recommended. Unfortunately, it is not always possible to cure an infection in a joint replacement. In these cases, permanent removal of the joint replacement may be necessary. It may also be necessary to consider amputation to control the infection. For these reasons, prevention of infections is extremely important. Prior to surgery, you will work closely with your surgeon to optimize all aspects of your medical history that could increase your risk of infection, such as tobacco smoking, diabetes, vascular disease, and obesity. A fracture is a broken bone that occurs around the joint replacement implant. This is a serious complication that most often requires additional surgery. Sometimes fractures occur during the surgery itself. However, the majority of fractures occur after the surgery, sometimes in the first few weeks, or sometimes after the patient has spent years with a successful joint replacement. Fractures most often occur after the patient has a fall. They can also be caused by higher energy forces, such as a direct blow to the joint or even a car accident. Some patients are at higher risk of fractures, such as people with osteoporosis, muscle weakness, poor vision, or poor balance. Patients who sustain fractures also tend to be older in age. When patients suffer a fracture, they often present to the emergency room because of pain and inability to stand on the leg. In the emergency room, your surgeon and the other doctors will diagnose your fracture with x-rays or other types of radiology scans. The fracture will then be temporarily stabilized in the emergency room. You will then be admitted to the hospital in anticipation of surgery to repair the fracture. Fixing the fracture will take place after the medical doctors at the hospital determine that you are stable enough to undergo surgery. Sometimes, orthopedic trauma specialists can fix your fracture without having to change your previous implant. Other times, the underlying joint replacement will need to be removed and switched to a new style of implant. This surgery will usually be performed by a specialist in joint replacement surgery. Following surgery to fix the fracture, older patients often stay in the hospital for a few days. It is also common for older patients to be discharged to rehabilitation facilities or nursing homes after major injuries such as this. Younger patients are usually able to go home, sometimes even the next day following the surgery. Depending on the specific nature of your fracture and the surgery that was needed to repair it, you may be allowed to put your full weight on the repaired leg, or you may be required to use crutches or a walker to keep your weight off the leg. Recovery after fracture repairs is often longer and more difficult than the recovery after your original joint replacement. There are a variety of complications that can occur after fracture surgery. In some cases, repeat operations are necessary to address these complications. For this reason, prevention of fracture is extremely important. Your surgeon will review all of the steps that you can take to prevent fracture and avoid falls after your surgery. Some of the things that you need to consider before surgery are having multiple people around to help you with your recovery, recovering after surgery in a house that only has a single floor with bedrooms and bathrooms, practicing with a walker or cane before surgery, rearranging furniture in your home, eliminating objects that you might trip over, and making a plan to care for large pets that might knock you over.
Dislocation means the ball has popped out of the socket. If your hip dislocates, your leg will be twisted, short, and painful. You will have to call 911, ride to the hospital in an ambulance, and then a resident will come and pull on your leg to put it back in the socket. It is unpleasant, and this is the reason why I recommend learning the hip precautions prior to surgery. When we study it scientifically, we can't show that following the precautions make any difference. So some surgeons say I do an approach that doesn't require the precautions, or I use a piece of technology that doesn't require you to follow the precautions. But when I do your surgery, I take the hip apart. So if that is the motion that takes it out of the socket, it makes sense to me to avoid doing things like that for 6 weeks, while a sleeve of tissue heals that will hold it in place after that. Then you can go about doing whatever you want. limb length discrepancy. If I'm moving your hip around with trial parts and it feels like it is likely to pop out of the socket when you roll over in bed, I will choose to lengthen your hip a small amount, a 1/4 inch, to make it stable. Most of you aren't equal heading into surgery in terms of leg length and won't notice a difference this small. But if you did, you could make up for it with a cushion in your other shoe. If you were lengthened by over 1 centimeter, sometimes it would make your hip on the other side, your knee on the same side, and your back sore. It would feel funny walking barefoot on the beach or across the floor to the bathroom at night. You can't make up for a difference that big with a shoe insert and would need to have your shoes modified. I have been able to avoid lengthening your hip by over a 1/2 inch in general. Thank you.
Instability refers to the ligaments that connect the bones. If these ligaments are under a nice, smooth, even tension as you flex and straighten the knee, they don't cause any pain. But if the knee can wiggle and jerk these ligaments every step of your life, it can cause pain and inflammation around the knee. While sometimes it is clear when it started, like after a fall, other times it is not. Instability is one of the reasons that you need surgery right away in the first year after surgery. It is frustrating for patients and surgeons. If you're having pain as bad as you do now after surgery, it usually means there's something wrong. Once you are through the initial healing phase of surgery and recovery, our goal is for you to have little to no pain. It is not uncommon, especially during the colder months of the year, to have some increase in everyday aches and pains. You should not need narcotics for more than 3 months following your surgery. If you do, we will need to see you in follow-up. Unfortunately, many of the problems that cause persistent pain after surgery require different treatments and further surgery to treat them.
One of the risks of total knee and total hip arthroplasty is getting a blood clot in the legs and/or lungs. The overall risk of getting a clot of some type is around 0.6% for a total hip and 1.4% for a total knee. A blood clot that goes to the lungs can be fatal. This is much less common. There can also be some other long-term consequences such as pulmonary hypertension and heart failure. We do put people on blood thinners that decrease the chances of blood clots compared to not being on any medicine, but we can't get that risk to zero. For most people, we use baby aspirin twice a day. For people with certain medical conditions or histories that make them higher risk, we may put them on more aggressive blood thinners. However, it should be noted that the more aggressive medicines are correlated with more wound drainage and bleeding, and therefore are not appropriate for everyone. Signs of a blood clot can be significant swelling of the limb, shortness of breath, chest pain, feeling lightheaded, etc. If you start experiencing these symptoms, you may need to go to the emergency room to be evaluated. If you do have a clot, you may have to be readmitted to the hospital and you will have to be placed on strong anticoagulation unless there is a medical contraindication. In the past, mechanical or aseptic loosening was a significant contributor to the failure of total joint arthroplasties. This was due to the interface/bond between the implant and the bone failing. Most of the loosening was a result of the wear of the plastic bearing surface. The tiny plastic wear particles would trigger an immune response by the body that would lead to the bone at the implant or cement bone interface undergoing resorption. This would lead to loosening of the implant and would eventually cause pain. In the early 2000s, cross-linking of the plastic was found to greatly reduce the wear rate. At this time, it appears that implant loosening due to this mechanism has greatly decreased since the advent of cross-linking. But it can still happen. If it does, revision surgery will likely be necessary. Stiffness can occur after total joint arthroplasty. It is much more common in total knees than in total hips. The best predictor of your postoperative range of motion is your preoperative range of motion. One of the keys to a successful total knee arthroplasty is getting the knee bending and extending. This process can be painful, and many, if not most, people require narcotic/opioid pain meds to achieve this. We have all had that patient come back to our office a week or two out from surgery that are happy to tell us that they are off of pain meds, but when we ask them to flex their knee, they can't. This is counterproductive. We do give the pain meds for the purpose of facilitating the rehabilitation of the knee or the hip. Pain meds will be discussed in further detail in another portion of this video. However, they are a crucial part of the road to a successful replacement for many people. Think of the process of getting your range of motion back as cutting down a forest. Opiates are like a chainsaw. They make the job much more feasible, but have to be used responsibly. If you are not achieving the progress that is necessary for a good outcome, we may need to bring you to the operating room for a manipulation. In this scenario, we will have you undergo anesthesia again, and we will carefully flex and extend your knee while you are unconscious to break up the scar tissue that has accumulated. There are risks such as fracture and tendon rupture with this procedure, so it is preferable to avoid having to undergo it.
Your body creates blood clots after cuts and bruises to stop you from bleeding. After surgery, you're at an increased risk of blood clot formation, but these clots can sometimes form inside of your veins, blocking the flow of blood, which can be serious. A clot inside your veins is called a thrombosis. A clot that's in your deep veins is called a deep vein thrombosis, or DVT. Thrombosis usually occurs in your legs, groin, or belly. Signs of a DVT include swelling or leg pain and tenderness. Your leg may also feel warm to the touch, and your skin may be discolored with a reddish or bluish tint. Sometimes a clot in your body may break off and travel to your lungs, which is called a pulmonary embolism, or PE. A PE is a serious clot and can be fatal. Signs of a pulmonary embolism include sudden shortness of breath, sharp stabbing chest or back pain, which might get worse as you inhale, a rapid heart rate or unexplained coughs, sometimes with bloody mucus. If you notice any of these signs or symptoms following your surgery, notify your Geisinger healthcare professional immediately or go to the emergency department. Best of luck with your surgery.
Our goal is to minimize your risk of blood clots following surgery, while minimizing your risk of bleeding from the medications we use. There are a few risk factors for blood clots after knee and hip replacement surgery. These include recent hospitalizations, long-term bed rest, limited mobility, and obesity. Medications used to prevent blood clots are called anticoagulants. These are commonly referred to as blood thinners. The benefits of anticoagulants in preventing blood clots are greater than any risks of bleeding. These medications can be given as an injection into the vein, injection into the skin, or by swallowing a tablet. Your doctor will determine which medication is right for you. Some of the medications used to prevent clots include warfarin, which is also known as Coumadin or Jantoven, aspirin, enoxaparin, also known as Lovenox, rivaroxaban, also known as Xarelto, or apixaban, also known as Eliquis. Your doctor will determine the amount of time you will need to be on a blood thinning medication. This largely depends on your surgery and likelihood for developing a clot. You can expect to be on this medication a minimum of 14 to 28 days after surgery. Your provider will assess your risk of blood clots and your risk of bleeding when selecting the right medication for you. Best of luck with your surgery.